So in preparing for this meeting, I was trying to ask myself the question of how many surveillance scans do we think we are carrying out in the UK? And of course, it's a very difficult question to answer. But if I took a wild guess, not quite wild, but back of the envelope calculation, I would estimate that it's in the territory of 100,000 scans a year. And that is a lot of resource, and it's surprising, I think, that we've got delivering that much surveillance, but there's so little scrutiny over how those surveillance scans are being distributed and delivered. And of course, this is in stark contrast to other screening programs, such as, for example, breast cancer screening, where you have very detailed level of information on coverage, number of early cases of early detection, false positives, and that scrutiny, that timely data, really helps to drive quality improvement, particularly around equity of access, which, as we've been hearing, is a huge issue when it comes to HCC surveillance. So this is something that we're very weak on at the moment with HCC surveillance. And of course, there is a huge difference between HCC surveillance and breast cancer screening, although both are recommended and recommended by NICE guidelines. HCC surveillance is not endorsed by the UK National Screening Committee, whereas breast cancer screening is. And because HCC surveillance is not endorsed by the UK National Screening Committee, it is not entitled, it does not receive central funding to support the infrastructure and delivery of surveillance and the sort of funding that would lead to bespoke data systems being set up to monitor the delivery. And so the question is, without that endorsement, can we do more to monitor HCC surveillance on a shoestring? And in this talk, I want to explore the possibility of using administrative routine data sets to do that. So what do I mean by administrative data? Well, essentially these are data that are collected to record and document routine NHS activities. They are collected primarily for reimbursement and accounting purposes. They're not designed with the intent of performing research, and they certainly haven't been set up to monitor HCC surveillance, but that doesn't mean that they can't be used in that way. And of course, the great advantage we have with administrative data is that you don't have to go out and collect the data yourself. It's already sitting there, and so that obviates the need for primary data collection, which, of course, as we know, is very costly and time-consuming. And one of the most important administrative data sets from a HCC surveillance perspective is the diagnostic imaging data set, which we've already briefly alluded to in this session already. This records the date and the fact and the modality and the body site of all hospital imaging procedures. And it's a data set that is derived from local radiology information systems. So local units submit their data to NHS England monthly, and then that data is then cleaned and then collated nationally. It covers the entirety of NHS England, and crucially, the data is individual level, which means it can be linked to other administrative data registries. But one of the limitations, of course, is that it tells you that a scan was performed of the liver or the abdomen, but it doesn't tell you why that scan was performed. So the question we were interested in trying to understand is, can we use the diagnostic imaging data set to measure HCC surveillance? So we linked a cohort of about 2,000 people with cirrhosis and cured hepatitis C, with about 4 years of follow-up data. We linked them to the NHS diagnostic imaging data set, And over that 4-year period, we identified just over 9,000 liver or abdominal ultrasound episodes. And we were also able to collect validation data from the clinics, directly from the clinics of these patients, that these patients were attending, data relating to surveillance scans that had been received. So we could essentially measure HCC surveillance in 2 ways, through the diagnostic imaging data set and then directly from the information collected through the centres. And we found that, we looked at this in a number of different ways. Firstly, we looked at the time interval between consecutive ultrasound events. And we found, this is based on the diagnostic imaging data set, and we found that on average these scans were taking place every 6 months, which of course aligns very closely with the recommended surveillance interval. So that's what we would expect to see if the DID was capturing surveillance adequately. We also looked at imaging procedures performed in those who had received a HCC diagnosis in this cohort, and we found a big spike in imaging procedures at the date of HCC diagnosis. So that, again, is what you would expect to see if the DID was capturing these imaging tests reliably. And crucially, we were also able to compare the surveillance uptake measured through the DID to the surveillance uptake measured from data collected by the liver centre. And in general, we saw very good agreement between those 2 ways of capturing it. So I would venture to say that yes, we can measure HCC surveillance using the diagnostic imaging data set. And the beauty of the diagnostic imaging data set is that you can link it to other administrative and routine data sets. As a simple example, we could go to the cancer registry and identify all HCCs in the cancer registry and then link those records to the diagnostic imaging data set. And then we could look at the amount of surveillance received prior to that HCC diagnosis. And we could look at the proportion of cases that received no surveillance in the period before their HCC diagnosis. And we could look to see if that proportion was changing over time. Was it going up? Was it going down? We could assess if things are moving in the right direction or the wrong direction. We could look to see if that proportion of people receiving no surveillance, if that's patterned by socio-demographic factors, by deprivation, for example, how it varies across the country. And we could report that data back to stakeholders, local cancer alliances, the British Liver Trust, for example, to really try and drive quality improvement. So that is just a simple example. But of course, we could link the diagnostic imaging data set to a range of further administrative data sets as well, to report on a broader set of HCC surveillance indicators, such as the hospital admissions database and mortality records as well. And then, in the fullness of time, we could even link it to the proposed cirrhosis registry, which would give us scope to report on a much broader set of indicators. So far from this being something that would compete with the cirrhosis registry, it would very much augment it and enhance it. So I think this is the future. This kind of approach is the future, and again, it's about preparing for this. So the benefits, as I say, are that these data are already sitting there. We don't have to go out and collect it, and as we know, primary data collection is very challenging. But there are obviously challenges to this approach as well. One of them being that although this approach is cheap, it's certainly not free. NHS England charge quite a hefty fee to access these data sets and link them all together. But if this was something that we felt would be useful in the long term, then we could ask NHS England to waive this application fee. So that's something we could consider. So in summary, population monitoring of HCC surveillance is weak, and that is a problem because if you don't have data to show that surveillance isn't working, then you can't argue for change, you can't lobby for reform. And we've already heard of other initiatives in this area, the Radiant project and Shine UK as well, which are also initiatives to improve population monitoring of HCC surveillance. But I think for a complete discussion on this issue, we should realise that there is an opportunity to be strengthening the monitoring of HCC surveillance using routine data that are already available, particularly the diagnostic imaging data set. Thank you.